Okay, you were going to tell us about erections, something about erections.
Right. Erections is the most important organ barometer on a man's body. Unfortunately, we women do not have that kind of barometer on our body. It's not that evident. You know, there isn't an end point to women's sexuality really, how do we really measure it? How do we really measure desire? How do we really measure arousal? With men, it's pretty easy. You either have an erection or you don't have an erection. You either keep it or you don't. So this is the most wonderful, wonderful organ on the man's body. So the erection is determined, and I wish I could draw. So I want you to, can I draw and kind of show you an image?
Yeah.
All right, so I'm going to do that. And let's just have a look at this and see if people can see this. So here we've got erectile dysfunction, and I hope they'll be able to see it. We're going to try it in any case. And here we've got cardiovascular disease, and here we've got depression. And then in between here, we've got diabetes. And then we've got testosterone. So let's just, if you can have a look and see that. Able to see that?
Just pull back a little bit. Okay, yeah. So at the top, we've got erectile dysfunction. In the center, we've got diabetes. Then we've got depression and cardiovascular disease.
And testosterone in the middle.
Okay, testosterone low in the middle. Got you. Okay, yes.
Right. T in the middle is testosterone.
Right.
So here is a man who is presenting to you with erectile dysfunction. Mm-hmm. What our responsibility is, because we are aware that there are 4 systems that control sexuality: vascular, neurological, hormonal, and psychological, we are obligated, we are ethically obligated to assess him fully for any of these other diseases, because there is a bilateral relationship between all of these diseases. So a man who comes to me with an erection difficulty, I have to assess him for depression. I have to assess him and send him to a cardiologist to go and get a full workup, because perhaps there is some kind of either blood pressure or cholesterol problem that is going on, or heart disease that's going on over there. And I also have to send him to a diabetologist to see, is there any diabetes? Because there is complete, and to go and get a testosterone check. There's complete comorbidity with all of these diseases. And this is called metabolic syndrome, right? This man is probably overweight. He's probably over 45, 50. He's probably got low testosterone, and he is smoking or drinking too much and not exercising. And he's going to present with an erectile dysfunction. That's kind of simple. That's easy. We need to know that that is essential for us to be able to present. Now, you may look at him and see he's overweight. You can ask, does he smoke? Does he drink? And he'll say yes, yes, or no, no. And even if he says no, no, you are obligated to make sure, assess him with the psychiatrist, send him for an assessment of depression, essential to send him for cardiovascular disease checkup, and for diabetes, and for testosterone. Because what researchers told us is that 2 to 3 years before a man has his first cardiac event, he begins to have erectile instability.
Wow.
Men who have cardiovascular disease will definitely have erection problems. Men who have depression will definitely have erection problems. Men who have diabetes will definitely eventually have erection problems. And low testosterone is going to be an indicator or lead to erectile dysfunction. Having erectile dysfunction is going to cause low testosterone. So we have to do a full-on assessment and full-on treatment plan for this man. But now it gets a little tricky. So here is the conundrum for the students. I'm going to tell you another case study of a man that I have just recently seen. So he presents to me, he's 35 years old. And because I'm a therapist, and you're not, I don't expect you to be, because I'm a therapist, I look for all the cues that are going to indicate to me what is going on from a biopsychosocial, relational, pharmacological perspective. And right from the minute that man makes his appointment, he follows up on a daily basis to say, confirming my appointment. So I know that there's a level of anxiety that's sitting over there. Okay, so that's my red flag immediately. I note it, high anxiety in this person. I note it, I assume it from some of his behavior, but I can't make an assumption until I have evidence around that. So he comes on and onto Zoom, and he lets me know, I can see, because I'm trained and training to be present with what's called sensory experiencing interventions. So I'm looking to notice the face, the gestures, the movements of this person. And I see that this man is very restless, he's very agitated, he can't sit still, and he can't look at me in the face, which is an indication of shame as well. And he's sitting in a room, because it's beautiful that we're able to Zoom to kind of get a multi-dimensional picture of Siobhan's pink and Siobhan's pink. We get a beautiful understanding or look into this person's intimate world. And he's sitting in a dark room, which is his office, he tells me. Everything's rigid, everything is, I can see, very controlled, very in order. And he says he's 35 years old, and he has been in a relationship, for a number of years, and he really suffers with erection problems. So I started the biological assessment in a very casual way and find that he has got no health problems. He's very fit, he exercises extremely, he eats extremely well, very, very healthy man. There is no problem with his numbers of blood pressure or cholesterol, nothing like that. And so I know there's no need for me to burden the healthcare system by sending him for those tests. He goes for discovery checkups, he's a privileged person, and I don't need to be doing that. So I know that there isn't anything. And in any case, at that age, unless there are any high numbers or indicators or medications that he's on, there's no reason for me to linger in the bio world with him, biological world with him. So clearly it's happening in the psychological, the social, relational world that is happening to him. And it emerges, that this man, he's taken Viagra, he's tried to take Viagra to help him with his erections, which is a PD5 inhibitor, hasn't worked for him. Hasn't worked? Well, it's a very safe drug, it's very effective. Why hasn't it worked? Because he's not taking it correctly, his doctor hasn't informed him, and also he's so anxious that he's taking it too much or too little. So it's not working. The drug works, he's not allowing it to work for him. Why? Why is he sabotaging that? And it turns out that this young man has got a massive intimacy problem. He's got a psychological problem of high anxiety. And he'll tell me, I'm very stressed. And I check in, how have you managed lockdown? And no, it's been wonderful because I can lock down and I can just work Why you want this consultation with me? Well, my partner's threatened to leave me, not just because of my erection problem, but because I'm just not present with her, because I neglect her, because I'm never around. What are you doing? I've just been working. So we know that working is a way, like drugs, to manage high anxiety. And so am I going to give him just medication for high anxiety or recommend that he goes to a psychiatrist? No, I'm going to first try and do some kind of therapy with him, which will immediately get his erection to work again. You cannot have an erection working with anxiety. So you can't just give the drug unless you're able to work with managing the anxiety of the person. Because as I've said, he's not going to be able to take the drug properly. He's going to override that drug with his anxiety, or he's just going to give up or not use it because he doesn't want to, because he feels out of control with it. And so we have a different way of treating him because the diagnosis is different. It's not an erection problem. It is a problem around anxiety, and he's created a performance anxiety, which gets him to have erection. And obviously for me, because I'm trauma informed, I go a little down, and there sits the trauma. The childhood trauma is there. A child who was really bullied, a child who was neglected at home, he had nobody to care for him. And that's what causes the inflammation of anxiety and therefore a sexual problem.
Sure, it's such a far-reaching and it really is biopsychosocial. There's no escaping that. I want to just highlight something that you said about learning to read body language, because I do a lot of training on intimate partner violence with the students, and I always talk to them about how your patient's body language is so valuable. You can pick up so much information if you are, as you say, just present in that moment and actually paying attention. So thank you for that. I'm going to pause us now before the next segment.